Our task is to just have a very open forum on active surveillance. I'll highlight some patients. This is just to observe something before we get started. I'll just show just introductory. Lori did a very good job the other day talking about active surveillance, so I'm not going to go through this in any detail, but as people are walking in, I think we're all well aware that prostate cancer mortality has declined, particularly in regions where PSA is used. Interestingly, I live in Miami, very close to Jamaica, where it's still a major problem because there's no use of PSA as a widespread early detection plan. However, we have a lot of patients with low-risk prostate cancer and would never have required treatment. And we all know that prostate cancer is really a unique malignancy for a variety of reasons, and I don't have to. On the other hand, I think this slide is really important. And we heard from Prime Minister Omert the other night, so it's very topical. When we say to someone you have prostate cancer, if you're the patient, right away you're thinking, I'm going to die within a short period of time. It's automatic. Even really bright people, it has that initial shock. And hopefully, as a physician, you can adjust their understanding. And I think it's really good that the New York Times and so many NBC News, et cetera.
So sorry to interrupt. It's just that you're on the webcast, so your back is to the camera.
Where's the camera? Oh, so I have to look at the camera like a TV show? All right, I'll stand up here. All right, but I'd rather be here, and we don't know how many people are listening to the webcast. Okay, that's fine. Feel like I'm on NBC News here or something. Okay. So at any rate, I think that's important. So do all men with 10-year life expectancy need treatment? And I've been on one of my things, Lori, I'll always remember I had you and Bill Catalona on the podium at one time talking about this. And literally, it's too bad we didn't have boxing gloves, although I think Lori would clearly have won. But I was nervous trying, Catalona on the one side saying if you have one cancer cell, for sure, you need treatment, probably your prostate out, and Lori is trying to give objective information that is necessarily the case. And I was happy when the session was over.
So was I.
So the concerns, however, for active surveillance, one, patient is always concerned, but they may miss an opportunity for cure. They're anxious. Personally, and this hopefully will come up, I don't think there are any medical legal issues. And really, I don't hear that much from urologists in the U.S. You document it, they understand what the story is, you indicate that they have the choice of treatment or not treatment, so I don't think any urologist will be sued. He may be sued if he didn't make a diagnosis, but once the diagnosis is made that he didn't operate or didn't provide treatment, I don't think that's an issue. Now, the problem, of course, has been traditionally repeat biopsies. We'll discuss that. Just a word, the physicians, I think, have an important role, and specifically urologists. And we wrote a paper a couple of years ago, which we took 185 of my patients that were in active surveillance, and we sent them by mail, and we asked them, the urologist who told you your diagnosis, did he even mention active surveillance? And we found that only a third of the patients, the doctor, the urologist who told them the diagnosis, even mentioned active surveillance. I don't know if that's changed in a couple of years, but I think personally, I think that's a problem. I'm going to skip this. There's a cost implication to what you decide. Personally, I think active surveillance is gradually gaining acceptance. So here are a couple, I think, basic thoughts. PSA increase alone, I think all of the studies, I think Dr. Klotz mentioned it the other day, is not a trigger to have treatment. Personally, I think we all agree to that. Gleason 6, again, was mentioned several times. Lori mentioned it yesterday emphatically. Rarely causes death from prostate cancer if it's truly a 6. The optimal monitoring schedule is not standardized, and hopefully we're going to talk today to some degree about the role of MRI, which has been a major point. Now, I thought important to mention these next couple slides. I received an email consult recently, so I haven't seen this patient. But to me, this is a big problem. This is a 71-year-old man who had a radical prostatectomy. He had post-op radiation therapy, possibly because of biochemical recurrence. I don't know, or whether it was adjuvant. He developed severe urinary incontinence. He had a sphincter placed. He had erosion. He had severe infection of the pubic symphysis, which required open debridement, hospitalized for a month, hyperbaric chamber. They got infected. They put a PICC line in. He still has serious urinary incontinence. Probably at 71, this was not a cancer that would have affected his quality of life. I mean, this may be a little bit dramatic, but it's a true case. And when I read this, I felt really sorry for this poor man. And I don't think this is this is extreme. But to some degree, I don't think it's rare. And Peter Carroll and I had a conversation about 5-6 years ago, and he said to me, in 15, 20 years, we're going to go down as what a disaster we've done with so many unnecessary treatments on some of these patients. And I know, again, I keep referring to Lori, but all of the people on this panel have been saying this for a long time. So let's start out. These are cases of mine, and please, everyone in the audience, Howard, welcome. So we have a radiation oncologist. Any other radiation oncologists in the audience? Oh, wonderful. So please speak up. This is I've got an open mic here. So if you have a thought, please, don't just let the panelists say everything. Okay, so I think I've sent you all the first part of each case. So Neil, we'll start with you. This is a 65-year-old man. He's overweight, 5'6", 234 pounds. Past medical history, he had an angioplasty in 2001. His PSA in 2007, 3.2. So you could say it's normal, you can say it's slightly elevated. He's got a large prostate, and you see the biopsy, 5% of one core, Gleason 6, and 10 biopsies were obtained. So he has some coronary artery disease, he had an angioplasty. Okay, Neil, how would you counsel this gentleman?
Well, I would first tell him that I thought he fits what I would consider most of the criteria for a very low-risk prostate cancer. He's got all Gleason 6, small volume, large prostate, has comorbid conditions, and even though I would talk to him about all of those options, including focal HIFU, which I'm not that, is clearly in the experimental realm, I would strongly be suggesting active surveillance for him. And I'd probably also recommend they go on a 5-alpha reductase inhibitor based on both the REDEEM data and the fact that he's a 77-gram prostate. I suspect there'll be a dual benefit. At least I would, have that discussion with him.
Okay. So I'm going to ask Neil first and then a couple of the other people. I'm going to call on everybody, but everybody that won't have to answer each case because I'd rather go through a lot of cases because each scenario is a little bit different. Why did he have a biopsy? Because his PSA was 3.2, and in the U.S. now, because of some of the work Catalona's done, we tell people over 2.5 that you have a 20% chance of having cancer. Pardon? Oh, that's a different story. I understand. You can argue he shouldn't have had a biopsy. That's not the point. He's had a biopsy. Your point's very well taken. I don't want to go in that direction. You're 100% right. Is there overdiagnosis? We know that. Absolutely. No, your point's well taken.
This is the one meeting where a Talmudic approach to the case can be taken.
Good point. So just from the audience, let's see. How many of you would say he should have his prostate out? He's a young man. Wow, times have changed. Radiation therapy, either 2 or 3. Nobody. Oh my gosh. Active surveillance. Gee whiz. We're talking to how many about HIFU? Some kind of focal therapy. Anybody focal therapy advocate? Get him over his anxiety?
In general 100%. Or for this case? In general or for this
case? This case.
I don't think it's unreasonable. I mean, depending on the patient's anxiety and desires for therapy, I don't think it's unreasonable to consider that.
All right, so Neil, you're going to put him, everyone wants active surveillance.
Yeah.
What would be your protocol and Claude?
I would speak against HIFU.
Okay.
although we don't practice it.
Focal, I'm not talking about whole gland.
Okay, even focal for several reasons. The main one is that even Gelé from Lyon developed it, and I went there, etc. For large prostate, they do TURP before. So that's the first anesthesia in a cardiac patient. Okay,
Good
no
point.
problem. First anesthesia. Then 1 month later, they do the HIFU, focal or not focal. So it's already 2 anesthesia without giving the patient the assurance that he will be cured, but it is part of a less active treatment. Then I would say first, if one considers this, I would eventually consider giving 5-alpha to reduce the size of his prostate, because even for HIFU it's way too big, or even for brachy, it's also too big. So you could also have another approach, because then if it's too big, several of these patients, and I've seen a few ones, they fall in retention, you resect them, and they got incontinent. So
Okay.
that's one
Excellent
of the stories.
points,
And that's an aggressive, indirect
So the way,
approach.
I'll just say that for focal HIFU,
Yeah.
and the way that we practice at our clinic for isolated patients, and these are rare patients, we do not need to do a TUR, because we're basically obliterating 10% of the man's prostate, and the functional outcomes are superb. We still need to know, obviously, about long-term.
But it's a large prostate,
Yep.
and there is a risk of retention.
Yeah, it's small, though.
Small.
I mean,
Okay.
But this, I assume you're starting with this case, because this case is at the
The lowest.
extreme end. He has absolutely no indications for anything. He is got significant comorbidity. He's got one core. He's very low risk, low PSA density. He has no driver for intervention, period. He doesn't actually have a disease. He has something that's part of the aging process.
Yeah.
And that's all we have diagnosed. So really, for this case, I wouldn't even give him the other options. I would say, you don't have anything serious. All you need to be is followed.
you're not going to tell me you wouldn't tell him that that a radical prostatectomy is an option for him.
No. I don't think it is an option for
Oh
him.
my God. Okay.
All right.
I think that would be the wrong treatment.
I agree with you, but to say, I mean, look at NCCN guidelines. I mean, these are all options. I would strongly steer him towards surveillance.
We
but
got the message. Let me move Haim and then Mark.
The only first of all, I would join Claude with the telling the patient the HIFU is not an option. Mainly, even if he wants to have, or we can do a focal, because in this particular scenario, you would need to repeat the biopsy to know exactly where the tumor is. So you just did a trust biopsy. You know it's 1 out of 10. But in order to do a focal, you definitely need this way or another to rebiopsy the patient. It's again. It's either done under anesthesia or it's, again, traumatic for the patient, and I wouldn't do it.
Good point. Mark?
I actually think my job is to help patients narrow down options, but not select options. I agree with the comment in the back that the time to narrow down to one option, doing nothing, was before you did the biopsy. After you do the biopsy, you have to talk to him, and you can help him narrow down options. And certainly, I think the only reasonable treatment option would be external beam radiation for this gentleman. But that's for the patient to decide now, because the one thing you don't know is what's inside his head. And if he really wants to be treated, you've made a diagnosis of cancer, I think you have to offer him that option.
Okay. Neil, let me get back to you in this. We'll come back. We'll have plenty of time for all of these to come out, I promise. Neil, will an endorectal MRI or other type of MRI provide useful information now going forward?
So the answer is probably. We are doing a randomized trial right now to answer that question. I do a lot of endorectal MRIs for a surveillance patient. This is one patient I would not do it in, because as we've shown, the real risk factors for underestimating disease is prostate volume, ironically the smaller being worse, or higher PSAs, of which this patient has neither. So, I would not, we're in a system where our resources are somewhat constrained, and I would not go out of my way and order an MRI for this gentleman.
Because you don't think it's going to add to...
I don't think it's going to add for this gentleman.
Okay.
I just want to make that point.
All right, we'll come back for others. Claude? You wanted to make a comment or about the MRI?
No. Well,
Okay.
for us, the cost is not a concern because we pay in our taxes the cost for the patient in our country. I think it's nearly the same here. But it's a part of the negative point. But I don't think that it will make a big difference also due to the size of his increased prostate, which is also,
Okay.
I agree.
So let me move on. Neil, keep up with you.
Yep.
So we did what everybody in the audience said. PSA then rose to 6.6. He had a biopsy again. Now, the size here is different. I probably did this one. So
there's a lot of errors in ultrasound estimation of prostate size for sure.
So now that here he's got 3 + 4, 3 of 8. So it's one of he was understage, whatever term you want to use, the extent of his cancer, but it's still the same patient. His risk is, he's not a cardiac cripple by any means. He's still relative, but he has to have a history. Now what?
So now he's entering radical therapy realm. He's had a PSA rise, which is disturbing. He's got grade progression or undersampling, 3-chords Gleason 7. He's still in his 60s, and he's had angioplasty, but he's not horrible. So most likely this gentleman will get a radical prostatectomy or external beam in our center.
Do you have a bias, a 65-year-old?
Yeah, personally towards surgery. I'm not particularly impressed with the long-term BNED rates with external beam. I think as time goes on, more and more evidence is suggesting that it doesn't work.
So, Haim, you have a lot of experience with brachy in particular.
Brachy is different.
Would you be an advocate, and what about
I would see him as an appropriate case to do brachy. The question whether it suffices to do a monotherapy brachy or, as discussed this morning, a combination of external press brachy is something which needs to be evaluated perhaps a little bit more carefully together with the pathologist to see the extent of the disease on the biopsy. That would perhaps change my opinion whether it's mono or combination. But yes, definitely it would be a good candidate for brachy.
Let's just see the audience. How many of you would prefer some sort of radiation therapy for this fellow? Maybe 30, 40%. Surgery, 65-year-old? Maybe 60 versus 40 here. Any other treatments, panelists, anything else? Laurie?
So there's a couple of issues. First of all, it's interesting his prostate is miraculously cyto-reduced from 77 to 45.
I can't explain it.
Well, we know there's, between observer variability. Yep. Still, so the percent Gleason 4 is relevant, and you haven't told us that. But the patients, the surveillance candidates who quite frequently have 3 plus, say, 5% 4, there's a whole phenomenon of overgrading due to tangential cutting of a Gleason 3 acinus where you lose the lumen. So I think it's important to try and establish how much Gleason 4 he has. And our approach to the 3 plus a little bit of 4 is to continue to offer surveillance, but based on an MRI. Because if the MRI is negative, the data we heard at this meeting from Rod Reiter notwithstanding, there is increasing evidence of a high negative predictive value for a significant amount of disease. So that would be the scenario where I think surveillance is still an option. And if he's got a target, then focal therapy may be appropriate.
Let me, again, I won't, even though you raise your hands, I want to really get a lot of cases. Howard, go to a mic because I'm going to ask you this question as well. Neil, back to you because it's your case. So the decision we made together was external beam. Does he need androgen deprivation? Let's say he had 20% of 4 in the...
In our center, he would not get androgen deprivation with EBRT. He's got classic intermediate risk disease, lowish PSA for that. It's not like it's a high intermediate risk disease.
What would be your break point?
I think if he was PSA 18 to 20, then that 20 range, then he would get it, but not here.
Okay, Howard?
I would be, before I recommended androgen deprivation or not, I would want to know a little bit more about the patient. I'd be interested in his sexual functioning and how interested he is in maintaining sexual activity.
Most men are going to say yes, even if they do or don't have great erectile function. That I can tell you.
So there's a randomized trial that shows a small overall survival benefit to the addition of hormonal therapy in intermediate risk cases, albeit with lower radiation doses. So in general, I recommend it for intermediate risk, but suggests that even short-term hormone therapy of 4 months can lead to a prolonged decreased ability in erectile function later on. So there may be a trade-off.
What do you think, Howard, his chance of dying of prostate cancer is at 65 with this disease?
I don't know, maybe 15%, 85% chance dying of other causes.
15%?
Yeah.
Okay.
I mean, I think the cardiovascular data also, and particularly with this gentleman with pre-existing CV disease, yeah.
Does he have hypertension?
He's had an angioplasty.
No.
It's controlled if he does, not a significant risk factor.
Because, you know, the data from the IC, the index of coexistent disease, is that someone who has two diseases, for example, hypertension and coronary artery disease, the median survival at age 65 is 7 years.
Wow, that's
so
impressive.
he has,
Yeah.
if he has two diseases, you know, diabetes and hypertension, that type of thing, he's really...
Would you give him androgen deprivation if you had the decision-making, Laura? You're sitting in a multidisciplinary meeting with your radiation oncologist, 3 + 4, certainly mainly 3, PSA 6.
I mean, usually the guys getting radiated have this decision made by the radiation oncologist, but I would say he would most likely get 6 months of adjuvant ADT unless he really was at high risk from a cardiovascular perspective. And a prior angioplasty I wouldn't call high risk.
Okay. Any of the others have any? Amnon?
It's intermediate risk.
To add is that there is a paper coming soon in urology showing clearly that young patients with comorbidities, basically the survival is the same with or without the cancer. So you don't need to take into consideration the comorbidities up to 3. But in the more old patients, the therapy for prostate cancer in a comorbid patient would be a waste of resources because usually they're going to die before any revenue from treatment.
So let me ask the audience. This fellow's going to have radiation therapy now. How many of you would say external beam is very reasonable, best form of treatment? IMRT.
It's not unreasonable.
You got to pick one. You're picking one. How about implant alone?
That's probably the best.
Very, relatively few, okay? Combination, number 3. Nobody. Proton beam? Probably you don't even have that here in Israel. I think that's okay. Haim, you wanted to make a comment? Yeah.
No.
What did you pick?
I would have picked implant alone.
Implant alone.
Yeah.
Claude, you agree?
He's got a rather low PSA, not a very high volume disease, small prostate, 45 grams. I would have picked up implant
Okay.
alone.
There's probably no winner. They're probably all going to be pretty darn successful, regardless. Okay. This fellow had external beam. He had no androgen deprivation, which personally I would agree with. 2013, his PSA is 0.44. So far he's a success, which is no surprise. Okay, the next one, Dr. Klotz and Dr. Matzkin, patient. 62-year-old, more or less the same, very healthy. He's got AFib, but he's doing great, looks fine. Uncle had prostate cancer, PSA 1.7. A urologist thought he had a suspicious DRE. This is not unusual in the U.S. for the gentleman here, so don't go there again. He had a biopsy in 2004, very focal, Gleason 6. Rectal exam, totally normal feeling prostate. His PSA later in the year, 2.3. Now, again, let's, Laura, you probably don't even have to have a vote, right? Anything that would sway you again?
I'm all for democracy, but the nodule is the issue, so it might be worth.
You mean
the
that
question is, what's the
understood?
significance of that nodule?
Well, I said he had a suspicious DRE.
Yeah, so the point is, if he's really what he looks like, which is microfocal Gleason 6, why has he got a nodule? So either the nodule is a nodule BPH, for example, or something else.
It didn't say nodule, it said suspicious. That's all I had in the record.
Enough to drive a biopsy
Exactly.
with a low PSA.
Exactly.
So you presume
point.
it's a little more than just slight
Okay.
asymmetry or something.
Fair enough. Fair enough.
But yeah, I mean, based on what we know so far, certainly surveillance would be the treatment of choice.
Okay, so let's Haim, you would agree with that?
I would agree. I would have probably gotten an MRI because of the suspicious
Good point.
DLG.
This
You
is
know, can I
now
just make
2005.
In my opinion, we should be doing MRI on all these patients after diagnosis of prostate cancer. We don't do that. Mainly it's a resource issue and probably some kind of economic analysis warranted just to confirm. But I think, clearly there's a role for this going forward. You find a big anterior target, you do target biopsy, the patient's benefit.
I would say, though, we still don't know the false positive rate. I mean, we're getting, we've lost our great MR person. He's gone to work over at Laurie's place uptown. But I could tell you we've been wholly disappointed of late with a lot of PRADs 3, 4 calls that are biopsy negative, driving up the anxiety, driving up the concerns. And I'm not sure the jury's out yet on this question. I mean, there's no doubt there's some patients with large anterior tumors. The problem is I can never get an MRI called normal anymore. And then you have to have this discussion with the patient. Well, you have a shadow here, you have something here.
Well, I'm glad I'm not the only one with this experience.
Yeah.
That's refreshing to hear.
At the clinic, we're beginning to take a very close look at MRI ultrasound fusion. Just for that reason. But you have to have a team of radiologists that are going to give you consistent readings. But I'm confident Eric Klein thinks that MRI ultrasound fusion is going to be the way to go in the future.
Yes, Amnon.
I would risk myself and say that if this guy doesn't have in biopsy high-grade prostate cancer with low PSA and palpable mass, maybe a neuroendocrine tumor, this is a wrongful diagnosis.
Well, we don't know that yet.
The one thing that has my hair up a bit with this case is he has a 20-gram prostate. And that should already start people's spider senses worrying about an anterior tumor. But we'll see where this goes, especially with a PSA of 2.
Very low.
It's
2.1 PSA density is fairly
It's not that bad, not that low for a 20-grammer.
All right, so Haim, continue with the case. So you see I did a repeat biopsy, no cancer. Next year, a little more than a year, he had 2 of 4 very small fragments of Gleason 6. The next year, another biopsy, left single atypical gland. The next 2 years later, the next biopsy, all cores negative. So I think, at least I'm pretty convinced with a small prostate, no MRI thus far, that this guy, so now he's gone 5 years, PSA hasn't changed at all. Can I stop doing so frequent biopsies, Haim?
I would probably increase the distance between the biopsies. I don't know if I would stop biopsies, but I would definitely anywhere between 3 to 4 years between biopsies right now.
Okay, we're on a good pattern. Laurie?
Well, you've already done too many.
Yeah, you might have skipped one.
The confirmatory biopsy is important. After that, I mean, the concept is you're looking for grade progression. And if that occurs at the rate of about 1% per year, which is what several people, including us, have estimated, then you can't make a case for doing it that often. If it's just a sampling issue, then you need to be perhaps doing more biopsy, more cores when you're doing it. But we after the second biopsy, which we call the confirmatory biopsy, then we extend the interval to around 4 to 5 years for the next one.
Okay, good point. Laurie, very quickly, and then Haim and anyone else, just one comment. Preparation pre-biopsy, Laurie.
Fleet enema, this is evolving. Our routine is just oral Cipro plus a shot of gentamicin if there's anything like prior Cipro or a prosthetic implant. But most people just get Cipro. I understand that probably 20% have quinolone resistance and that it's probably not adequate, but we haven't changed our approach to that yet. We've looked at, rectal cultures, but that's actually quite a cumbersome technology. It's expensive to do the anaerobic cultures, et cetera. So ultrasound guided, local anesthetic. There's an art to the local anesthesia. If you do it right, I think it's quite effective. And template, I'm not a fan of. And what do you mean by label location?
Do you think it's critical to say right, left?
Yeah, it's critical. And
how is it going to change the treatment of the patient? Assuming he's not going to get new, some kind of focal therapy.
But that's the point, is I think you can't ignore focal therapy. It's coming, and if the patient ends up with an MRI, you want to know how does the site of the positive biopsy correlate to what you see on MRI. You have to label them individually.
And I think for your surgery, it's good to know where your bulky disease are. Is it median or lateral for nerve sparing? It's helpful.
Well, but this guy doesn't.
I know, he probably won't. But in general, it's good to have one standard way of doing it for everyone.
Okay, Haim?
I would do exactly the same. We prepared patients exactly the same schedule for antibiotics. I would do exactly the same thing. And I wouldn't do a template in this particular case, although I do quite a bit, but not in this particular case.
Yeah, before I ask, how many of you, just a couple things. How many of you use enemas? Do you think it's important for a patient to have an enema? How many don't use enemas? How many don't know what you do? Or someone else, the radiologist. Personally, I never did enemas. I don't think it's helpful. I think it's, and there's one or two studies, not huge studies, that show it makes absolutely no difference. And so I don't do that. Claude, any comments?
No.
And also,
to save a
oral
mess,
Cipro
really,
alone, we had to stop. We give her a cephalosporin IM, because our sepsis rate was up to about 3%. And now with the IM plus the 3 hours before Cipro has made a really significant difference. So at least, again, it's regional. Depends on your Cipro resistance. Mark, you were going to make a comment?
We use Levaquin and Gent on every biopsy.
Everybody gets gentamicin.
Levaquin and Gent.
Yeah.
I am?
Yeah, I am. Yeah, I'm sure. You do a urine culture before everyone?
Then it comes as a question. If they have any kind of an implant which is earlier than 2 years, we add augmentin, and we very easily move to cephalosporin if there is any kind of hint, like previous treatment with Cipro or stuff like that.
All right. So now the time is moving. I'm going to really move along very quickly here. Lori, this gentleman now in 2012, you probably read ahead already. PSA hasn't changed. He's now 70 years old. He's been 9 years on active surveillance. You have a lot of these people. Now what? Follow up.
So he's gorgeous. You made the right decision. He's done well. You continue to follow him. I see these patients once a year from the first year, and I do the biopsy about every 5 years until about age 80. That's, oh my goodness, the ravages of age. Wow. And then I stop as they approach 80, or if they have significant intercurrent.
All right,
illnesses.
so I can lay off most of the, except DRE and PSA and rare. Okay, now we're going to bring into age. So Claude and Mark Stovsky in this case. 36-year-old, healthy man. Hematospermia in 2002. He had it again in 2005. PSA, you see, is very low, no family history. DRE, small, normal. So 36-year-old, that's his PSA. Claude, would you do a biopsy?
Regularly, I would not standardly do biopsy in these guys, but since he has repeated hematospermia...
Do you have a mic that works in front of you?
I would first consider doing an MRI, definitely.
Really? Okay.
Yeah, I would do an MRI, because having hematospermia, I want to see if the MRI can make a difference between a cyst on his seminal vesicle or some suspicious lesion, and I would do that before considering biopsies.
Okay, all right.
I would certainly in a young guy.
But he would get a biopsy regardless of your MR result.
Mark, what would you do with this fellow?
There was a report several years ago about the risk of prostate cancer and hematospermia, but in a 36-year-old with no risk factors, this patient I would have gotten a urine cytology and no prostate biopsy.
Yeah, so naturally he did have a prostate biopsy or we wouldn't be talking about him. So again, very focal, active surveillance treatment. So let me ask the audience, 36 years old, bottom line age, is there a limit where you really wouldn't suggest active surveillance no matter how little the cancer is? How many thinks he has to be, really should be treated? He's 36 years old. Nobody. So on the, some of the panelists, but no one in the audience. How many therefore, just to vote, active surveillance is acceptable in a 36-year-old? So how many of you didn't raise your hand because you're just not sure of the answer? Okay, fair enough.
Can I just, my understanding of the way to manage this PSA, which is significantly elevated for his age, is not to biopsy, but to follow him with annual PSAs.
Right.
I mean, that's the whole kind of ERSPC, EAU guideline shift. So do other people think that the biopsy here was appropriate?
I do, strongly. And I would get an MRI on this guy.
Yeah,
Okay.
MRI, sure.
These are all
After.
10 years ago
Antibiotics
cases.
also, check his PSA after
You know, if I'm a
long period.
radiologist in the audience, or I'm a urologist thinking, should I go now do a radiology residency? If I'm a radiologist, I'm going ka-chink, 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 music to my ears.
So just to get 1.6 PSA is highly abnormal for a 36-year-old. The average PSA for men in their 40s is 0.4. That's the median of the population. This is even in their 30s. It's like 0.3. 1.5 is the worst 5% in that age group, assuming no prostatitis, etc.
Could be infection.
Yeah, but that...
So let me, Claude and Mark. Mark, you're going to just watch this guy. You already told me, for the moment. Cytology and that's it, right?
Yeah, but I would not have done a biopsy. Once you have a biopsy,
now what?
everything changes.
But
To me, everything changes.
And would you treat him? The audience says no.
I would definitely offer him every treatment option available, without question.
Without question, you're going to suggest it? That's your best option?
Well, I think, 36, he has a very long life expectancy. Even a slow turtle is going to crawl from New York to California at some point, and I think
what do you
that.
think he says? What's my chance of dying of prostate cancer?
Well, I don't know if it's really estimable at 36. With his, he on average, he's going to live another 50 years.
Right.
And I'm not 100% sure you can calculate that right now. I'd like to see his PSA doubling time for a while and see what that does.
Oh, so you're going to initially follow him now. You're changing a little bit.
If I'm going to offer him everything, I may, if he asks me what to do, I might watch his PSA doubling time for a while. But I don't think it would be wrong to treat this gentleman. The youngest patient that I treated in my practice was 39. And I just think it's pretty difficult to wake up every day when you're 36 for the rest of your life knowing you have prostate cancer.
Yeah, but what if you have ED and you're 36?
No, I understand.
Okay.
I understand.
All right. Or you've got the guy who has that sphincter and is incontinent and he's been miserable.
Right, but if this cancer progresses over the next 10 years, you're going to have a headache.
Fair,
No,
fair
but
enough.
I would tell the patient at this particular age that he needs to look forward for another like 10 or more sets of biopsies if he stays on active surveillance, which is definitely something he will want to consider after having one set of biopsies at the age of 36. He will need at least 10 biopsies until the age of 80.
Okay.
So it's something to
Just to
consider.
move on, we had the discussion. This fellow, this is 2006, he had a prostatectomy. He made the decision. He had a very small cancer, margins negative. Thank God he's continent, he's fully potent, et cetera. And I'm sure that not necessarily my surgery, but he's 36 years old. Okay, now let's go. I said young and old. This case, same group. So Mark Stovsky, let me begin with you, and then Amnon and Claude. 76-year-old, but very fit man. This guy swims every day. He's in super health, very bright guy, mentally perfect. He had a recent TURP for lower urinary tract symptoms in 2005, so 9 years ago. PSA very low. He had a small focus, and I haven't read the slides myself, 4+3. Rectal exam normal, very small gland. So I guess, because he's 4+3, he's not T1A. Probably have to say the old post-TR T1B.
Yeah.
What to do?
Well, the first thing is I would really question the 4+3 reading. With a very small focus, I think all bets are off on that reading, and I would probably at least get another opinion on the pathology and potentially do another biopsy to confirm that, to make sure it's 4+3. If it's 4+3, I think to me, age makes a big difference, in all honesty. Even if they're very fit, it still makes a big difference. It's unlikely in my practice, assuming the pathology is correct, you can make an argument for watchful waiting, not necessarily even active surveillance, but watchful waiting. But if you're going to offer him options, I would not really be talking to him about a radical prostatectomy. I think the options for a 76-year-old man are really, in my practice, are going to be focused on external beam because he's had a TURP, so I would probably stay away from seeds in this patient because of the risk of incontinence after his previous TURP.
So let me ask the audience. Have a vote, make the case quicker. How many would choose 1 or 2 radiation therapy for this guy now? The radiation oncologists raised their hands. Okay. No, I say you did raise your hand. I saw you. But we only have 2 or 3 votes. How many would just observe this fellow? Active surveillance, again. We got a lot of proponents here. Surgery, anybody?
I'll make a proponent. That's what I would do.
Repeat TUR. Okay. Yeah, I should have put that.
That's what I would have done.
That was sort of no problem. And HIFU. All right, let's see what we did. So I didn't do that initially. Mark Stovsky, I'll stick with you for the moment.
Okay.
Here's his PSA, so we followed him. Any change?
No.
I guess I didn't rebiopsy him right away. Maybe I didn't see him at this point.
There's no change in my decision making, and 1 or 2 are what I would be looking at, either watching them or external beam.
Okay, so I did take him, did an ultrasound guided biopsy, only Gleason 6 and 2 of 6 cores. And the PSA after that 1.3, I did another set of biopsies, 2 years now after his TUR prostate, focal Gleason 6, so no sign of any 4. Can I continue active surveillance?
Absolutely. Mark? I mean, that was the whole purpose for questioning the small focus of 4+3. You've confirmed that he's low risk now.
If I can make the case, you have not reassessed his transition zone, which is where the tumor was to start with. So you've done a peripheral zone, maybe, but I mean, I think a repeat TUR would be much better way, along with a peripheral zone biopsy, which you've done. If you want to watch him, I think that's the way I would go.
I don't know.
I would disagree with that. Claude, help me out here.
I think that first is prostate BPH, so-called, is gone. It was removed. So what do you want to rebiopsy transuretrally? Will certainly not be the one that is significant. It will be in his capsule or outside. So for me, doing a second TURP.
Well, many of these are anterior in the...
okay, anterior you can see with an MRI.
2009.
Rebiopsy. Oh, I would not make it so complicated. The guy is already closer to 80.
Right.
Leave him alone.
He's 80 years of age.
Okay.
Yeah, the morbidities of a repeat TUR far outweigh the morbidity of a well-done transition zone biopsy with peripheral zone biopsies, and that's, I think, the way that I would go.
He has predominant Gleason pattern 4. He has real cancer. He should be treated. A TURP is not an adequate treatment for...
No, the TURP would be a staging, because if you re-TURP him and get a bunch of 3, then he's a 3-4, not a 4-3. And I'd be more inclined to watch.
All right, so at this point, 2009, question now, audience. So now you see he's still got very small volume. His PSA hasn't changed at all. Okay, he's 80 years old at this point and fit. What would you do? 80 years old, but he's got 4+3. So yes, he's got a real care. How many would continue active surveillance, which we've done for 5 years? About 30% of the audience. How many would say external beam? No. Another third. Any other treatment? No. Howard, you voted for watching him? Now he's 80. You'd observe him?
Yep.
Okay, you're not on a fee for service where you are. Sinai. Vito, how did you vote? You would observe. Okay, all right. He's happy with observation. If we think it's safe. Yeah, of course that's important. Laura, you're arguing for treatment of him now?
Now listen, I mean, we've been over-treating low grade, but we also have been under-treating some patients who have the real deal. And my basic frame of reference is that Gleason 3 and Gleason 4 are completely different. Gleason 4 is a aggressive, potentially life-threatening, potentially metastatic lesion. You're telling us the guy is very fit, so he may have 10-year life expectancy, certainly from when he was 78. And I think he should be treated.
There's no right or wrong here. Your point is well taken. We discussed it extensively. He went with the majority here. He elected, he says, I'm okay with active surveillance. I was convinced with his PSA not changing that it was small volume, even though, yes, of course, the 4+3 worried me. At any rate, he's now 84, he's in super health, we're good friends, etc. Next case, Dr. Zisman, we're going to start with you and then Neil. 43-year-old healthy man, married, no family history of prostate cancer, normal physical, prostate feels normal, PSA has ranged, as you see, over the years up to 2.3. Biopsy he had because of the 2.3. He's 43 years old, so now we're back to a very young man. 1 of 9 with 10% of one core. Again, same sort of thing, nothing's 43-year-old.
No, I would not.
No active surveillance for him. Okay, let me just continue then. This man elected to be monitored, so he said, okay, Amnon, you're a respected doctor, but I've read about all the articles, I want to just be observed. His PSA then went to 4.3, a biopsy now has 2 of 8. On the prostate exam, slightly firmer on the right side, but I'm not sure really what that means. I'll just go forward. He had a radical prostatectomy, and so far so good. His PSA is slightly elevated, so we'll see. There's a good one. Amnon, we'll keep up with you. 76-year-old man. Actually, this guy lived in Israel for many years, so now you're going to be really sympathetic towards him. He had a flower shop in Dizengoff.
You really collapsed my argument because I calculated white male American survival.
No, this is a different patient now. 76-year-old healthy man with new diagnosis in 1994. He had a normal exam, PSA 4.3. He had a biopsy done in 1994. He was 76, 1 of 6, 10%. What would you have suggested to him in 1994?
Well, I thought you're giving me a math exam, and I went to the U.S. registry for life expectancy.
Okay.
And look on his cohort, taking into consideration his age and some kind of a bias caused by the Second World War. And I really learned the subject. And in 1994, his survival, his life expectancy was, well, I prepared a slide on that, but I remember it's something like 8.7 years.
Okay, Laura,
So
you're an expert at this. He's probably correct, huh?
So he was less than 10 years. And the other issue, the other time point was, I don't remember, maybe it's the next slide. So I thought on watchful waiting because active surveillance was not available in 1994 as far as as I remember. But then the next point that you mentioned, maybe in the next slide, at that time he had a life expectancy of 2.8 years, and therefore I even not do a biopsy on him.
Okay, very good point.
A confirmatory, it's not a confirmatory biopsy in fact, but according to the timetable that was detailed there.
So I think based on this audience here, I think everyone agrees that active surveillance would be reasonable with this gentleman. And here you go. His PSA was active surveillance. His PSA has gone up to 7.7. He's now 95 years old, very active and good health. So I think we made so far a very good decision. What's his life expectancy now at 95? 2.6 years?
Between 2.8 and 4, depends if he's Hispanic or white or...
I can tell you he thinks it's 15 years. So we'll see. He lives in South Florida, so I'll continue to follow him and I will let you know. Claude, next patient, 80-year-old, general healthy man, 2010 PSA 5, rectal exam feels benign, biopsy low volume Gleason 6. He was put on active surveillance. Now he's 80. Gleason 4 plus 3, 2 millimeters in 1 of 10 cores, PSA 5.9. So his PSA is about the same, but now we've got this ugly Gleason 4 staring at us, but very small.
Probably it was missed on the first biopsy also, since his PSA did not change. This is considered as his status. That did not change in the 1 year time frame. His PSA remained the same. He has Gleason 4 plus 3, and so it seems to be very stable with this. I would continue to follow him and do his PSA 3 times further.
So you want to continue to follow him? He's 80 years old?
Yes, because his PSA did not change in 1 year. So in fact, in 1 year, he had active surveillance.
Good point, yes.
So he is already on active surveillance.
All right, so let's ask the audience. How many would continue just observing this? How many would continue observing this man? Wow. How many think he ought to be treated? He's got a potential. So you have 10% here. Yes, sir, you had a comment or question. Yes.
Deals with the different questions, so...
That's all right, you can ask it now. Go ahead.
Close the case? Okay.
Yeah.
Okay. My question actually goes to the future, say 2 years or 3 years from now, because we are recruiting more and more patients. I think adoption of active surveillance is going, and now we see more patients of young age, and taking those 2 cases that you presented with very young patients, I assume that in 2 or 3 years we would see more MRIs coming in, we would see more targeted therapy coming in, and my question to the panelists is, I suppose that we would see a stage migration due to the use of targeted biopsies. Now, giving current recommendation and guidelines, suddenly you may expect higher Gleasons or more hitting of the target. So how would you expect us to deal with that? I mean, giving the current recommendation and a change in the future, which is, I think, imminent.
So the real question
very
is,
challenging problem.
Is finding more areas within a prostate going to change things? But will it still be based on the Gleason score regardless?
We are using rules that were made in an era where we didn't have the technology. Now with the new technology coming in, there are bound to be more hits, more Gleasons, which are upgraded. And these are patients that will be recruited within the next few years. We'll have to tackle that soon.
The other thing that you're likely to see is newer and better biomarkers, including genomic biomarkers that are able to assess the aggressiveness of cancer better. And I think that's going to help make decisions in these patients.
Claude?
Our diagnosis may and will improve. There will be already genetic markers to see who will be at higher risk, and we will have a better selection of patients. But nothing is going to change the natural history of the disease.
But I think...
Not technology, except if you go in a polluted area somewhere maybe. But if you have a Gleason 7, and it is proved on 7, it does not change from 10 years ago to in the next 10 years. And if your diagnostic method is improving, that's one thing. But the natural history is the natural history of the disease.
Good point.
And this shouldn't change.
Laurie, I gathered you were going to, the audience clearly says continue monitoring this fellow, but I gather you thought different.
I mean, why was he biopsied? To my mind, if he's in good enough shape to have a serial biopsy on surveillance, because the biopsy has shown you what you're looking for. He's been upgraded to, predominant Gleason pattern 4, and that to me is a trigger for intervention. Just to respond to that question, we're going to have to completely recalibrate how we interpret volume when you start doing targeted biopsies, because you have a 1 centimeter cancer, you may get 4 out of 4 targeted cores showing 100% core involvement. So I think the big advance is to stop treating microfocal Gleason 6. Beyond that, that will be a huge benefit to patients starting already. Beyond that, if we do targeted biopsies, we find some higher grade cancer we would have missed otherwise. the patients actually may be benefiting from having that treated, whereas they would have stayed on surveillance.
Let me just respond just a second, Neil, to your point. And I was thinking about it really quickly. It's a good point. So if I get you right, you're saying, why did you biopsy him if you're not going to follow what the biopsy said? Is that what you're saying?
Well, you're biopsying him to find occult higher grade cancer, which
correct.
you've now found.
Okay. So you're not suggesting I shouldn't have biopsied him?
I'm saying that the decision to biopsy and the decision to treat are related. Because if the patient is not a candidate for definitive local therapy because of age or comorbidity, then that is the point at which you stop biopsying.
Well, we have a slight difference which we can carry on later. My thinking is, anytime you take on someone with active surveillance, you have an obligation to some degree that this man will not die of prostate cancer. Because you're staying on the front end. I think that it's safe. Otherwise, you would take Bill Catalona and operate on anyone with 3 glands of cancer. If your main goal was to cure people, you would have to tell them, if I do active surveillance, you have less chance you have more likely to die of prostate cancer than if we treated you. Even if it's 5 more patients out of 1,000 or 10,000. So, let me just finish. Therefore, once you take on some of the active surveillance, my goal is, if he has Gleason grade 4 or 5, I have to try and find it. Now, if you think you can do it with MRI, terrific. I can't do that with MRI. So I think it's my obligation. So now I sit down. I would say, just like the audience, I think active surveillance is still reasonable, but there's another choice, and because of this, you may want to elect it. Then it's up to you. So I think you're obligated to, one way or another, find out whether he's got a worse cancer.
If you're going to do something about it.
No. Okay, we'll continue this. That's up to the patient.
Just a
Claude.
short question.
Yeah.
When do you stop to make the PSA? I think a patient is 80 years old. I just make a digital examination. If the prostate is normal, no nodule.
But then you're in watchful waiting.
I don't do any
Okay.
So I
any
think
PSA.
that's the key point, is when do you shift from being a surveillance patient to a watchful waiting patient?
Exactly.
And usually around late 70s, early 80s is when that happens, at which point you're going to stop treating. I think this patient needs treatment mostly not because I think it's going to save his life. I still think he's at a very small risk for death, but these patients can end up on hormones in their late 80s, which is a disaster.
Well, it's not a disaster.
Well, they age. They don't do well at all at that age on hormones.
Okay, that's a whole different question. We don't have time. Just audience again. So you've heard this back and forth. How many think you now have to admit? I know you voted once. How many think, like Lori, this guy should be radiated? How many think active surveillance or watch whatever you want? Okay, the majority. Yeah. Oh, very quick. This is important. Testosterone. Lori and Haim. 63-year-old healthy man, 2005, low testosterone, 150, T level on exogenous T is 539, PSA is 5, DRE normal. Biopsies you see here. So he's got 2 small areas of Gleason 6. But he is symptomatic pre-exogenous. He feels much better. Quality of life parameters all much better. Claude, you can jump in on this too. Number 1, audience. Can I continue him on active surveillance? How many? Wow. How many say no? You have to treat him. Oh, okay. So we don't have many people voting. Okay. How many, if we do active surveillance, how many say we can continue to give him testosterone? How many say no? You have to stop it. How many don't know the answer? Okay. Fair enough. So this is I don't know, I see really not a small number of such patients. This is a major thing. So Lori, Claude, Haim. Lori?
So look.
Answer both questions.
My personal view of this goes against what I consider to be the conventional wisdom. The conventional wisdom mainly articulated by Abe Morgenthaler, based on this so-called saturation hypothesis, is that once patients have a kind of bare minimum of androgen, that represents 100% of the prostate cell stimulation. Any further androgen makes no difference. In my mind, that is one of the most simple-minded and misleading hypotheses, and it is a hypothesis, even as he states it, that I've ever heard. And biology is much more complex. And my view is that it's very plausible that some prostate cancer cells can be stimulated by higher levels of testosterone. There's uncertainty about this. So if you have a guy who is really symptomatic and his testosterone is very low, then you can make a case. This is a classic risk-benefit trade-off that we make all the time in medicine. But the problem is a lot of these guys, their symptoms are vague. They didn't have much change in their symptoms.
No, this guy, very clear, he is much better off.
So I'm just telling you, in the more kind of borderline case, I tell them to stop it. This may be a guy where you say, look, we don't really know, but you clearly had some significant benefit. So, and another concept is say, look, you've been diagnosed with a pseudo disease, and why should that stop you from having a treatment that's helped you?
So what is your final answer to 1 and 2? Yes, he can continue on active surveillance?
Yes,
he meets the criteria.
For sure, yes, he can continue
and
on
he can continue on T.
It's a discussion.
Okay, perfect. Claude?
Well, I share your view, but you can also have a different approach, theoretically at least, by saying he was diagnosed with a non-aggressive cancer and low testosterone. Like you would
speak a little bit louder so they can hear you.
Yeah, like you will have in intermittent treatment, for instance. It's the similar situation. So eventually he continues his testosterone, and you have a very good marker, which is his PSA. If his PSA starts rising a little bit, you change your attitude. You have a thermometer. On the contrary, it could well be, it has been demonstrated several times, that low testosterone is more associated with aggressive cancer than the opposite. So maybe by giving him, I know it could be the opposite theory, by giving him what he is missing, which is testosterone, his cancer can disappear. Like in young men who have high testosterone, they don't have cancer. Old people have low testosterone, they have cancer. So it could be just the opposite of the traditional wishful thinking. Is this guy, in fact, maybe developed prostate cancer because he has low testosterone, and not the opposite.
All right, interesting hypothesis. Haim?
To me, Claude is going a little bit too far. I mean, we are giving the patient testosterone in order to cure him when he has prostate cancer. That's a bit too far for me. I don't know any guidelines that lets you give testosterone to patients who are not treated, who have no history of past prostate cancer and have now no evidence of disease. Obviously, with surgery, it's easier to follow them up. With radiation, it's a little bit longer. But I'm not aware of any guidelines letting you do that. So I would talk to the patient and tell him that if testosterone is of extreme importance to him, the price to pay is probably be treated for prostate cancer, cured of the disease, and then he can continue the testosterone for the rest of his life.
Well, just to get to I elected to the active surveillance. He wanted it. I think he could stay on testosterone. We monitor it. Everybody else with focal prostate cancer, they have normal testosterone. Why shouldn't he? He actually, after 5 years, refused any further biopsies, so he's currently doing well. We haven't changed anything, and he's still on testosterone, doing quite well. We've tried to, yes, quick question? Microphone.
So it's a treatment.
To reach a level of testosterone 5 plus nanograms per deciliter, this is a supraphysiologic level. So if you go down to a normal lower level like 300 or 350 nanograms per deciliter, maybe his PSA is going down and then you're more happy.
Good point. Yes.
I think we missed a unique opportunity with the first patient that's overweight to be physicians as well as urologists and tell the patient, refer him to a surgeon for barosurgery, a sleeve gastrectomy to reduce his metabolic syndrome, which will have a greater impact on his life. And I can tell you from personal experience, when patients hear that from an oncologist or urologist and not from their family physician, it has a lot more clout. So in addition just to saying, well, you can do active surveillance, you can tell the patient, you can do something to save your life as an overweight person.
Excellent.
And if you can't diet, send him to a barosurgeon.
Very, very good point. Well, our time is up.
Surgery as treatment of prostate cancer.
At any rate, we can continue this out. I don't want to hold up the next session. Thank you all. Great.
Thank you.
Thanks.